first, the second, 1, 2, 3, 4. We want back up. You had something. So what's this? I thought.
Kelly?
Yes, sir.
Yeah, we will start.
Right.
Let them keep on joining. By the time we'll be.
Okay, sir. We will start then. Just give me a minute. Good evening, ladies and gentlemen. Welcome to Secrets of Neurology, Knowledge Feast for all neurologists. Today, we have with us the team of SWIMS Tirupati. A very warm welcome to our course directors, Dr. Shah and Dr. Lakshmi Narasimhan. Because of their unflinching support in academics, this is now the longest running web series in the field of neurology. Today is episode 29 and we intend to conclude it by 9:30. It is my honor and privilege to briefly introduce our program director, Dr. Sudhir Shah, professor and head of department, NHL MMC and SVP IMSR Ahmedabad. Sir is also the director of neuroscience, Sterling Hospital, Ahmedabad. Sir has got many laurels and accolades and is author of 6 books. Because of his patients and community at large and research, Dr. Sudhir Shah has also been conferred with Padma Shri. Sir is also the recipient of B.C. Roy Award and many other accolades to his credit. His area of interest is stroke, neurodegenerative diseases, and epilepsy. The equally competent is our second course director, Dr. Lakshmi Narasimhan Sir, Director and Professor, Institute of Neurology, Madras Medical College, Chennai. The same institute where he started as a student and is now heading the department. Many affiliations and awards to Sir's credit: Palatucci Advisor Award from AN, A.B. Baker's Award for Global Best Teachers from AN, Best Paper Award at AN. He is 3 terms executive member in the Indian Academy of Neurology and also a CME convener at Indian Academy of Neurology. May I now request Sir to take it forward from here and introduce the speaker.
Thank you, Heli. Can I have the slide, please? Dr. Abdul Hakim, the senior resident from the Department of Neurology, SWIMS, Tirupati. Thanks for accepting our invitation and looking forward for your presentation. Dr. Raghu Nandini, senior resident, Department of Neurology, SWIMS, Tirupati. Dr. Sai Arun, senior resident, Department of Neurology, SWIMS, Tirupati. And Dr. Srija, senior resident, Department of Neurology, SWIMS, Tirupati. Professor Nandagopal, Institute of Neurology, SWIMS, Tirupati, currently working as professor in the Department of Neurosciences, completed his DM Neurology at NIMHANS, one of the outstanding student in NIMHANS, and I know him for so many years, 2 decades of clinical experience. He did his fellowship in Canada, and he's a fellow of American Academy of Neurology, Royal College of Physicians, and ANA, several peer-reviewed publications, and in reputed journals, Neurology, Brain and Annals of Neurology. Wonderful academician. Welcome you to this Secrets of Neurology, Professor Nandagopal. Madam Bhuma Venkamma, Director, Vice Chancellor, Senior Grade Professor of and Head of the Neurology of SWIMS Tirupati. Madam is one of the doyens of neurology in Andhra Pradesh, and Madam has been the Vice Chancellor of the prestigious SWIMS and Sri Venkateswara University. Madam has started as did her DM Neurology from NIMHANS, and she started an establishment of the Department of Neurology in SWIMS, started the Journal of Clinical and Scientific Research, Padmavati Medical College, exclusively women medical college with 150 girls. Under her leadership, was started in 2014. under the government sector for the benefit of Rayalaseema. As a president of the Indian Epilepsy Association, Tirupati branch, lot of social activities, outreach activities are well known, with epilepsy are being organized in the form of conducting epilepsy camps, awareness programs, and the epilepsy in the society. Conducting regular monthly free epilepsy camps since February 1999. Approximately 400 to 500 poor patients with epilepsy are getting benefited regularly. And Madam is a mini fellowship program in sleep medicine, the Northwestern University School in Chicago, Illinois. Awarded the Vikruti Ugadi Visishta Puraskaram 2010 for the exemplary services in the field of medicine by the government of Andhra Pradesh. Madam is a teacher and guide manpower development, teaching experience of 31 years. Professor of Neurology since 2002, a senior grade professor since 2012. Research projects and drug trials around 16. Thesis evaluation, more than 60. She has been a chief guide and co-guide for 18 of them. Publications of 95. Book chapters are 7. Madam, I welcome you to this Neurological Secrets 29th episode. Over to you, Madam, and take over the proceedings. Thank you.
Thank you, Dr. Lakshmi Narasimhan, and I really thank Dr. Lakshmi Narasimhan and Dr. Sudhir Shah for giving this opportunity to participate in this Neurology Secrets. I think for the last 29 months, every last Friday, it's really academic feast, especially instead of routine didactic lectures, the interesting case discussions being held with the clinical discussion from the history point of view, examination, how to come to conclusion. From all the institutes, it is being organized regularly. I really thank them. And today's, we also thought we have a case, young lady with movement disorders, where it could be of definitely clinically interesting for the point of discussion. And in this case was detailed worked up by Dr. Nandagopal. I request Nandagopal to take over and see that all the residents present in sequence, and maybe I will towards the end will have a concluding remarks. I once again thank Intas and Dr. Lakshmi Narasimhan for giving this opportunity for our Department of Neurology SWIMS to take part in this Neurology Secrets. Thank you.
Thank you.
Okay, it's our honor and privilege to participate in this wonderful academic feast, and we thank the course directors, as Madam also thanked them. At the outset, I just want to sing a small song that could capture the moment. Like actually, SWIMS is located in the abode of the shrine of Lord Venkateshwara. And all of you will know about this world famous shrine here. So one day I was walking in the campus, and there was that cashew nut tree that bloomed, and then there was a fruit. I smelled some aroma, and then a small song came to me, and then I just want to sing here, like it's in Tamil. Hope some of you may be able to understand and appreciate. Maybe that Lakshmi Narasimhan will can understand it. So that song something runs like this. Puttirukkum poonjolai pudumanandan veesum காத்திருக்கும் கண்ணிரண்டும் கண்டதனை பேசும் ஏத்திடவும் எழுத்திடவும் எழுமறையான் வாசம் சீத்திருத்த சீலரவர் சிந்தை கொலும் தேசம் பெரும்பூதூர் மாமுனி போல் பெரியவர்கள் வாழ்க அருமுகிலாய் நேர்மையுந்தான் திருமலையில் சூழ்க கடவுள் என்றால் காசலவே கருத்துகளும் கோடி நாம் கண் திறந்து கண்டிடுவோம் மடமைகளை மூடி. Basically, it is about the nature and the nurturing of the nature. And in this endeavor, I just thought about the various religion cultures that coexist in our country. And then the great religious reformer is the Perumbudu Mamuni, the Ramanujacharya. And so what I mentioned was like we should take part in his footsteps, and we should embrace the people of all sect and religion. That's the principle we follow in our institute as well. And this song, I took inspiration from another movie song actually. So it goes like that. Actually, that actor Kamal Haasan was participating in the birthday or some wedding anniversary of his ex-lover, and then he sang like it is a lyrics by a poet. It says, "Nalla nalla manam vaalga, naadu potra vaalga, தேன் தமிழ் போல் வான்மழை போல் சிறந்து என்றும் வாழ்க, பூவுலகின் லட்சியங்கள் பூ போன்றே வாடும், தெய்வ சொர்க்க நிச்சயம்தான் திருமணமாய் கூடும், பொருத்தம் என்றால் புது பொருத்தம் பொருந்திவிட்ட ஜோடி, நான் புலவன் என்றால் பாடிடுவேன் கவிதை ஒரு கோடி." So we have a new pair like Dr. Sudhirsha and Lakshmi Narasimhan. They have been doing this academic feast, and so we thank these kind-hearted souls for the spirits and for imparting academic knowledge throughout the country and globally. And so now I will just give this podium to our young, enthusiastic four residents. They work hard to work up this case, and they will take us to the corridors and lanes of the clinical symptom science to reach a destination that is a working diagnosis and the management. First, the history will be narrated by Dr. Abdul Hakim, and he will also give us the analysis and the clinical stem from the history.
Good evening, everyone.
Just ask whether you can see the slides.
Good evening, everyone. Can you see the slides?
Speak onto the mic a little.
Yes. Yes, madam.
Just ask whether you're not.
Yeah, we can see the slides. You can proceed.
Thank you for the kind introduction, sir. I'm great. Thank for the madam and the faculty for the Department of Neurology for great. It's privilege to present in this platform. I'm going to present a case of a 57-year-old lady who presented with progressive slowness of basic activities of daily living, including walking since 1 year, and falls which are frequent since 1 year, and speech disturbances since 6 months. History of presenting illness. She had slowness in brushing, bathing, etc., which was insidious in onset and gradually progressive, which are involving slowness was involving both upper limbs and lower limbs symmetrically, which is associated with stiffness of limb. However, not associated with tremors, and no symptoms are suggestive of depression like sad mood or crying spells, and no symptoms of hypothyroidism. She had slowness in walking with small steps. She used to walk with small steps, difficulty in initiation and turning around, which was associated with freezing episodes, which were more during turning around. And next complaint, she was having falls, which are since 1 year. She used to fall like a log of wood, either forward or backward, with a frequency roughly around 4 to 5 times per day. She used to fall when walking for even for short distance and turning corners, which was not associated with loss of consciousness, and no other symptoms suggestive of inner ear pathology like giddiness or tinnitus or earfulness during episodes of fall, and no sensory symptoms like paresthesia or cotton wool sensation in the distal extremity, lower extremities, and no preceded sweating or palpitation during episodes of fall. However, these falls are not associated with major injuries, no history of falls on strong emotions like crying or laughing. And next complaint was she was having speech disturbance since 6 months. She used to talk very slowly and low volume, and there is no explosiveness in character and no slurring of speech, and no other elements of language involvement, like naming, reading, writing, she could able to do. The other relevant neurological history we got it is like she didn't endorse any history of memory or cognitive impairment or visual hallucination, no history of seizures, no symptoms suggestive of depression, and no sleep disturbances, and no history of hyposmia or major visual impairment or hearing impairment, no limb symptoms like resting tremor or postural tremors or weakness in the limbs or abnormal posturing of limbs, or no symptoms suggestive of dysautonomia like abnormal sweating pattern or postural giddiness or postprandial fullness or bladder and bowel dysfunction. From the past history, she has given history of total thyroidectomy 10 years ago for the follicular carcinoma of thyroid. And she has got vascular risk factors like hypertension and diabetes, which is well controlled on medication. However, there is no previous history of stroke or transient ischemic attacks. And she was taking thyroxine supplements like 125 milligrams per day after total thyroidectomy. And there was no history of exposure to other herbal medications or antipsychotic drugs like risperidone or antiemetic medication like levosulfide, and no history of chemotherapy or radiotherapy following thyroidectomy. From the family history, she no similar complaints in the family, and other complaints like slowness of activities or dilating that were not there, and she used to take mixed diet and sleep was normal. This slide will give the illustration of timeline of events, that is neurological symptoms started around 10 years after the thyroidectomy. Like age of onset of age around thyroid carcinoma was diagnosed around 47 years of age, and thyroidectomy done immediately, and then she was on thyroid supplements. At the age of 56, like she started to having bradykinesia and gait difficulties, and within a few months she noticed frequent falls. So these are the frequent falls within a 1 year of symptoms of bradykinesia is most likely to be red flag for the Parkinsonism. So next, I'm going to analyze the symptom one by one. Like bradykinesia, she was having initial symptom. That bradykinesia, there is no symptom suggestive of psychomotor slowness or crying spell or anhedonia or suicidal ideation, and depression was not there in this patient. No other symptoms of cold intolerance or dry skin and constipation. Hypothyroidism couldn't be the cause for bradykinesia in this case. And then no other behavioral syndromes like catatonia was not there, and no history of fall during sudden strong emotions like crying or laughing. That cataplexia, drop attacks is least likely cause for the bradykinesia in this case. And next symptom was like falls, which she used to fall like log of wood, either forward or backward, which is not without loss of consciousness. So falls broadly categorized in the elderly, falls without loss of consciousness or with loss of consciousness. With loss of consciousness, mostly we see in syncope or seizure activity, or with transient ischemic attack, mostly posterior circulation strokes. And falls without loss of consciousness, non-neurological cause could be arthritis or fragility or ataxia, abasia. Neurological causes could be like weakness because of pyramidal tract involvement or extrapyramidal lesions causing rigidity or fall, and lower motor neuron lesions like neuropathy or large fiber neuropathy causing sensory falls, and myopathy causing falls. So for neural substrate for gait and balance, here she didn't endorse any history of giddiness or inner ear pathology, so least likely the cause for the fall in this case. And there is no history of paresthesias in the distal lower extremity. That means the proprioception most likely to be intact and least likely cause for the falls. The vision is normal in this case and no limb incoordination. That means no cerebellar ataxia that is leading for the cause of fall. And she got bradykinesia, could be the lesion at the basal ganglia or circulate its connection. And she has other speech disturbances in 6 months, which is decreased in volume and low monotonous loudness, and which is intelligible. There is no slurring of speech during talking, and no echolalia or palilalia, no nasal quality of speech. This likely to be hypokinetic dysarthria. And then from the negative history, she didn't endorse any history of visual hallucination or cognitive or memory impairment, less likely to be the cause for the dementia with Lewy body. And she didn't have intermanual conflict, which we usually see in specific degenerative conditions like cortical basal syndrome or falling stroke. There is no other non-motor symptoms of Parkinsonism like depression, hyposmia, sleep disturbances, or dysautonomia was not there in this patient. And then limb symptoms like no resting tremors. So typical Parkinsonism couldn't be the least likely to the possibility. And no postural tremors and no weakness in the limbs. Pyramidal lesions are least likely possible. And no abnormal posting. So dystonia, seizures were not there. And low limb incoordination, cerebellar lesions are least possible. So from this present and past history of the patient, we synthesized clinical stem like elderly female presented with bradykinesia, postural instability, hypokinetic dysarthria, without tremors and no other autonomic dysfunction. In the setting background history of follicular carcinoma of thyroid, she was operated. So for the likely localization for this case is like around the basal ganglia and their connections. This diagram will illustrate the direct and indirect pathway, how the basal ganglia is involved in the movement initiation or termination of movements with the thalamus and cortex. So likely etiology could be, we could synthesize from the past history, like she underwent total thyroidectomy for the follicular carcinoma of thyroid 10 years ago. So maybe tumor-related complication like local infiltration to cervical spine or mets to the brain causing these neurological symptoms, like surgery-related iatrogenic hypothyroidism or hypoparathyroidism could be the possible we could think of, or post-surgery related chemotherapy or radiotherapy, though this patient is not underwent any chemotherapy or radiotherapy. And she has got vascular risk factors like hypertension and diabetes, which is well controlled. And there is no history of previous history of transient ischemic attacks or previous stroke. So vascular Parkinsonism, which is involving both lower limbs, may or may not be the possibility in this case. From the history, from the clinical stem, and we could localize to basal ganglia circulatory, leading to atypical Parkinsonism, and potential etiology. We could synthesize like iatrogenic hypoparathyroidism following history of thyroid carcinoma and following surgery for thyroid carcinoma, or could be other possibility like mets to brain with past history of thyroid malignancy. Least likely to be vascular Parkinsonism, though she didn't get any history of previous stroke. There is no history of exposure to drugs, and drug-induced Parkinsonism is likely in this case. Thank you.
So after the listening to the history, we'll go to the geography class. Like we'll negotiate through the GPS of clinical symptoms and signs through the corridor and lanes and turns to reach a destination that is a clinical diagnosis. No. Okay. Yeah. Now Dr. Nandini will provide the examination findings and refine the localization and the likely etiology.
Good evening, everyone. I'll be presenting the examination part of the patient with symptoms narrated before. Am I audible now?
Yes, Amma, you're audible. Just speak little loud onto the mic.
Okay. Her general physical examination revealed post-thyroidectomy scar in the anterior part of the neck. There is no lymphadenopathy. Her blood pressure is 110/70 mm of Hg. There is no postural, significant postural drop of blood pressure. We performed MOCA score in this patient. She scored 21 points out of 30. She studied up to 10 standard. She missed the following points: 5 points in visuospatial or executive function, 2 points in abstraction, and 3 points in delayed recall. She has motor preservation on Laplace test. She has impaired Luria's hand sequence. Lympraxis, she's not understanding the instructions well, probably due to spatial and temporal errors in phantoming the motor tasks. She has hypophonic dysarthria with the decrease in loudness and monotonous speech. In cranial nerve examination, she has slow saccades, both horizontally and vertically, with mild upgaze impairment with cogwheel pursuits. Other cranial nerve examination is unremarkable. In motor system examination, she has rigidity present in all the limbs with cogwheeling in both upper limbs, with power being normal in all 4 limbs with bilateral plantar flexors. She has diminished reflexes in all limbs with bilateral ankle absent, probably due to secondary to diabetes. She has positive glabellar tap and bilateral palmomental reflexes were positive. Sensory and cerebellar system examination was unremarkable, except she has difficulty in performing tandem gait. Cranium and spine was normal. There were no signs of meningeal irritation. We performed the motor examination of the patient. This is the clinical video of the patient. On asking the patient to perform repetitive finger tapping, you can see she has slowness with mild slowness with decrement in movement. When she's asked to perform repetitive hand opening and closing, you can see she has slowness in movement, and also there is a decrease in amplitude as with she has slight difficulty in standing up from sitting posture. However, she managed without any support. She also has slowness in foot tapping. On gait examination, you can see she has broad-based stance with initiation hesitancy, with short shuffling gait while walking. She also has severe turn hesitancy, taking multiple steps to turn, and she's walking like as if the foot are glued to the floor. She has also some freezing attacks in between. You can see she was stuck here and she was not moving. She was walking short, shuffling gait. On performing pull test, she had a significant positive retropulsion. She would have been fallen if not caught by the examiner. Here we have tested for the postural tremors on outstretched hands. You can see there are no postural tremors. Here she was tested to look for any presence of rest tremor. Here she has no rest tremor even with the distraction on performing mental arithmetic activity. You can see there are no rest tremors. Her MDS UPDRS score of levodopa was 33. On general physical examination, she also have a positive Chostek sign with Trozier sign. Summarizing the case, a woman in her 6th decade with short history of progressive symmetric limb and axial bradykinesia with limb and nuchal rigidity, with freezing of gait, significant starting and turning hesitancy, with marked postural instability and absence of rest tremor in limbs, with history of recurrent falls without any features of dysautonomia, with upgaze restriction, with slow saccades, and visuospatial, executive, and memory domains being affected, localizing the lesion to basal ganglia and its circuits, with cognitive impairment, mostly subcortical, as she didn't have any other features of aphasia, apraxia, or agnosia. Red flag signs suggesting other than Parkinson's disease in this case are early gait disturbances and with frequent falls within 1 year, with symmetrical signs and early cognitive impairment and absence of rest tremors. The potential etiologies could be in this case like vascular Parkinson's, as she has vascular risk factors for like hypertension and diabetes. Although she didn't have any history of past stroke or stroke-like episodes, or didn't have any stepwise progression or hypothyroidism in the context of post-thyroidectomy status. However, she didn't have any other features of hypothyroidism, and she also has extrapyramidal signs. As parathyroid glands are hidden in the thyroid gland, they could have been probably removed while performing thyroidectomy, leading to iatrogenic hypoparathyroidism, leading to secondary Parkinson's, and other possibilities like with short duration history, you can consider encephalitis, but she didn't have any REMS with behavioral disturbances or autonomic features or bulbar symptoms. She with history of underlying neoplasm, follicular carcinoma of thyroid, paraneoplastic etiology could be thought of. And lastly, Parkinson's plus syndrome like PSP with frequent falls with mild upgaze restriction can be possible. Thank you.
After navigating through the history and geography, now we move on to some physics, that is imaging and chemistry, to fine tune the diagnosis. Now, Dr. Arun will walk us through the imaging and the lab works.
Good morning, everyone. I hope I am audible to everyone. Am I audible?
Yes, Amma. Yes, go ahead.
Okay, ma'am. I'll be interpreting the radiological and lab data in this in this given case, case number 1, among other few interesting cases. This patient with this clinical history and examination, Parkinson with the diagnosis, with provisional diagnosis of Parkinson plus. This patient was subjected to MRI.
Yeah, it's visible, Amma. Go ahead.
So this patient was subjected to MRI brain to rule out any secondary causes. And the T1 sequence showing hyperintense lesions in bilaterally symmetrical and also bilaterally dentate nuclei is hyperintense on T1 sequence with not much hyperintensity on T2, and flare is showing subtle hyperintensity on the caudate region and thalami, bilateral thalami. So here I would like to focus on T1 hyperintensities as seen here in the caudate, the lentiform, the bilateral thalamus, and bilateral dentate nuclei. So with this imaging findings and with this clinical history, anyone want to take a shot on what the differentials might be in this case? I'll hold for 5 seconds maybe. So before going further into case number 1, I would like to share a few interesting cases with T1 hyperintensity that we have encountered in our institute. So this is a case, this case number 2 is an 8-year-old boy who presented with progressive foot dystonia with the age of onset at the age of 4 years, and no history or suggestive of any dopamine responsive dystonia or Wilson's disease. And this is his gait. So this is a cock walk gait. So this child was subjected to MRI showing bilaterally symmetrical hyperintense T1 hyperintense lesions in the bilateral basal ganglia and in the central tegmental tract, pontine tegmentum, which is giving the appearance of a horseshoe mustache. And the SWA in this MRI is showing no evidence of blooming, although there is some movement artifacts. There is no evidence of blooming. So what further tests in this patient? It revealed the child has polycythemia or erythrocytosis and slightly elevated transaminases. The liver screening showed MRI T1 liver screening showed the T1 hyperintensity of the entire liver. So what biochemical test next? So this child had elevated serum manganese levels, and the genetic test that was performed here in this case showed pathogenic variant of SLC30A10, confirming the disease, confirming the diagnosis of hypermanganesemia with dystonia type 1. So this is a case number 3, is an elderly female non-diabetic who presented with complaints of acute onset left hemichoria. So this lady showing the MRI is showing T1 hyperintensity in the striatal region, more on right side compared to the left. So this is a case of diabetic striatopathy. She had uncontrolled sugars. And this case number 4 is a 46-year gentleman presenting with progressive cerebellar ataxia and vertigo of 4 months duration. So the MRI show in this case showing T1 hyperintensity extraaxial lesion, which is T1 hyperintense, arising in the right cerebellopontine cistern and pushing the brainstem to the opposite side. This is a case of neuroenteric cyst, which shows biopsy proven with proteinaceous material within the lesion. So these are a few T1 hyperintense lesions. These are the substances that has a very short T1 recovery. So that's the reason for hyperintense on T1 sequence, methemoglobin, melanin, lipid, protein as seen in neuroenteric cyst, proteinaceous matter, minerals like calcium, manganese as seen in case number 2, iron, copper, diabetic striatopathy, cortical laminar necrosis. So these are the few substances that appear hyperintense on T1. So coming back to case number 1, so the further sequences in case number 1, SWA and face showing blooming bilaterally symmetrical in the corresponding regions as mentioned previously in the bilateral basal ganglia and bilateral dentate, and face sequence is showing silver lining which is corresponding to the skull bone, which implies that it is a calcium deposition, and it was further proven through CT, which is showing bilaterally symmetrical calcifications, striato, pallido, thalamic and dentate calcification, and also subcortical calcifications are noted. So these are a few differentials for the above image on CT, and the endocrine causes being the most common. So among which the parathyroid disorders are most commonly seen, and other causes being idiopathic familial bilateral basal ganglia calcification, which is known usually as FAST disease, And these are a few other differentials for this calcification in the bilateral basal ganglia and dentate nuclei. So coming to lab investigations, this lady had hypothyroidism, very low PTH levels, and associated with hypocalcemia and hyperphosphatemia, with normal vitamin B12 level, and the thyroid profile showed euthyroid state in this lady, in this patient. And other investigation like paraneoplastic profile and vasculitic workup was negative. Ultrasound thyroid was done. It revealed only post-surgical status and no evidence of any left out thyroid or recurrence malignant tissue was found on ultrasound. So based on this lab investigation, this lady has iatrogenic hypoparathyroidism in the setting of total thyroidectomy, which resulted in hypocalcemia with hyperphosphatemia. So coming to the final diagnosis after this clinical history and lab and radiological data, this child is likely to be suffering from secondary Parkinsonism of most likely with a PSP phenotype, probably secondary due to the iatrogenic hypoparathyroidism leading to hypocalcemia and hyperphosphatemia, which resulted in bilaterally symmetrical basal ganglia calcification and bilaterally in the dentate region as well. Thank you.
Now, finally, for the case one, Dr. Srija will provide a brief review of the literature.
Good evening, everyone. Hope I'm audible.
Yes, Amma, you are audible.
So to put together, the patient had history of thyroid carcinoma and she underwent total thyroidectomy, following which she developed iatrogenic hypoparathyroidism manifesting as hypocalcemia and hyperphosphatemia, leading to increased cellular calcium and phosphorus product, which is getting deposited extracellularly, especially in the basal ganglia, leading to secondary Parkinsonism. So the incidence of iatrogenic hypoparathyroidism post-thyroidectomy ranges from 0.9 to 5% post-surgery. And the prevalence of basal ganglionic calcification of hypoparathyroidism ranges from 25 to 74% as per literature. So other treatable, potentially treatable causes of secondary Parkinsonism are mentioned here. The most common being drug-induced. This illustrates the importance of taking a good drug history and to look for structural causes leading to secondary Parkinsonism based on clinical history and examination and imaging. And it is good to take a history of exposure to toxins, and manganese being an inherited cause, as we have seen in this case number 3. And copper transport defect leading to Wilson's disease is another potentially treatable cause of secondary Parkinsonism. So in a patient with neurological manifestations following cancer, potential causes could include metastasis and paraneoplastic syndrome, and other consequences of treatment, that is problems related to surgery and results of hypothyroidism and hypoparathyroidism. So in this case, the etiology would be iatrogenic hypoparathyroidism leading to basal ganglionic calcification presenting as secondary Parkinsonism. Calcification in hypoparathyroidism are the manifestations of poor calcium control. Higher the serum calcium phosphorus product, faster is the progression of basal ganglia calcification. So the exact mechanism is not known, but because of lack of PTH signaling, which is necessary for fine balance of calcium phosphate exchange between the intracellular and extracellular space, which is lost, leading to calcium phosphate deposition mainly in the extracellular space of basal ganglia, leading to calcifications. So these are the various manifestations of hypoparathyroidism. In this particular case, we have Trousseau sign, Chostek sign, and basal ganglionic calcification and extrapyramidal symptoms. So the management of post-surgery hypoparathyroidism, acute therapy is indicated only in patients with symptomatic hypocalcemia with corrected calcium less than 7.5 milligram per deciliter. Chronic therapy with the oral calcium carbonate and vitamin D supplementation daily is needed. If the calcium levels are not controlled with the oral therapy, we have FDA approved recombinant PTH injections available. So this prophylactic calcium supplementation after thyroid surgery is not recommended in all patients. The patients at risk of developing hypoparathyroidism can be identified by measurement of PTH on the morning after operation, which accurately predicts about 99% of cases leading to that develop post-thyroidectomy hypoparathyroidism. The goals of chronic therapy is to maintain the serum calcium levels within a reference range of 8 to 9 milligram per deciliter and to maintain the calcium phosphate product less than 55 milligrams square per deciliter square, and to maintain 24-hour urine calcium less than 4 milligram per kg per 24 hour. These are to be measured at least once a year. So the patients may remain asymptomatic at least a decade after surgery, which is seen in this case. For every 1% increase in calcium phosphorus ratio during follow-up, the progression of basal ganglia calcification can be decreased by 5%. So the take-home message from this case illustrates the importance of taking a good past history and identifying secondary causes of potentially treatable causes for Parkinsonism. In this patient presenting like this, we usually think of degenerative phenotype, but it is good to look at identify secondary causes of Parkinsonism that are potentially treatable. Thank you.
So that is the case number 1 in more detail. Now I just want to wrap up this case, and I just want to share some few other cases that may be of potential interest to all of us. So now I'm going to give you a cocktail of cases, not just to intoxicate you, but to add it to the title, like the importance of having a full closure of the clinical diagnosis. I don't have any disclosures, like so neurology is like mathematics, like you could create many formulas, like as I'm going to illustrate. So as in other neurology secret series, like mine is also going to be more of a case-based learning and teaching exercise. And I have assembled some few cases of interest to all of us, like so all along I will be just touching upon the underlying etiology. And so in this era of COVID and other bugs, like we need to wash our hands. So because we are moving virtually from different cases, we could wash our hands, at least virtually. And then because we need to be mindful of the so much microbes and multi-drug resistance bugs. So just a few reflections on the case 1. Like the first case illustrates the importance of taking a good past history. As you could see in this particular case, there's a period of 10 years from the time of surgery to the onset of her clinical manifestation. Maybe she should have some minor symptoms perhaps, but she came to the medical attention a decade after surgery. And then the secret is like the parathyroids are in the thyroid gland. So when thyroidectomy is performed, you can get iatrogenic hypoparathyroidism, especially if there are no ectopic glands. And also the radiotherapy also could cause some problems. And also during surgery, when they apply diathermy and all, the parathyroid gland could get injured when the surgeon performs thyroidectomy. And so this case, we negotiated from history to geography and to physics, the imaging and the chemistry. And all this tidbits of information, the piece of the puzzle could be unraveled when we put all of them together. It's just connecting the dots. And from a diagnostic etiological perspective, so we are moving on from untreatable neurodegenerative phenotype like PSP or SCARS to a potentially treatable condition. Perhaps progression could be arrested by the calcium and the vitamin D supplementation. In this particular case, actually, she was last to follow up. And then when we called her, like she unfortunately passed away some 6 months after receiving diagnosis from our institute. So now I'm just switching gears. I'm going to just touch base upon few other cases that could be of interest to us. I hope the time permits me to present the 2-3 cases, but just I want to be very brief to the point. So some few years back, I encountered this man in his 60th decade. He has seen many different specialties like ENT, gastro, urologist, etc. So basically had about some hearing loss, impairing his communication. That has been deafness has been present for nearly 5 years or so, and had a very severe obstructive sleep apnea for nearly 4 years. He was a slightly obese guy. And then he had of neurological interest, a dysphagia for liquids and more than solid. And it's a long-standing history of constipation. And there's an obstructive uropathy for which he was taking tamsulosin. And he also had on ENT evaluation, vocal cord paresis, more of bilateral abduction restriction on laryngoscopy. And they also have some vascular risk factor. And outside MRI shows some abnormal signal in the pons as well. And general physical review reveals some kind of obese or overweight guy with some impaired glucose control. He's a non-diabetic, and he had a lot of tests done by gastro and others, and as you could see here. And he underwent a sleep study also. He had a severe obstructive sleep apnea. His apnea-hypopnea index was 120, and he was prescribed a CPAP, but he was not using it regularly. And on neurological examination, his cognition is relatively preserved, as you could see in the graph depicted here. Most of his cognitive domains were relatively preserved, and he has the speech sort of a bulbar dysarthria. And as you could see the figures depicted here, like when he was asked to move to the right, the photo, the upper panel, you could see there's a restriction of abduction in the right eye, the adduction in the left eye. Perhaps the abduction restriction was more than the adduction restriction lag. And in second, you could see the eye in the primary position. And in the third lower panel, you could see it was asked to make left gaze, and there was some restriction of left ocular abduction that was more than the restriction of adduction in the right eye. And so he has some gaze plus or minus some abduction restriction as well. So he had mild orbicularis oculi weakness, and his gag was sluggish. Of note, he had a history of progressive dysphagia. And he didn't have much of a long traction except for slightly slightly brisk reflex, probably, or nearly normal reflex. Like now, when you come to localization, especially at the level of brainstem, if it's unilateral cranial involvement, we like to look for contralesional long track signs, except perhaps in the case of trochlear nerve, because it has decussation. So we also try to look for this kind of things like horizontal gaze paresis could suggest some intrinsic lesion, and then presence of INO, Horner syndrome, etc., could come to some rescue in differentiating whether the lesion is intrinsic versus extrinsic to the brainstem. So of note, this case is bilateral clinical findings. Now I'm just switching gear. I'm just trying to give some clinical flavor for the sake of residents. Like this is a case I saw in SIMS some 2 decades ago. Like this patient came like a presentation with a stroke-like symptom. So as you could see in the figure A, he had a tongue deviation to the right side. And in the insert, like figure B, you could see when he was asked to keep his hands in supination, you could see the left hand was slightly down, dropping, and then he had some amount of pronation as well. Basically, he had a left pronator drift. So he had right lingual paresis and left pronator drift. So this is a cross neurological deficit, cranial nerve deficit on one side and contralesional pyramidal signs. And you could also note here, like he had some limniscal sensory loss, impaired touch and joint position sense. And so the localization could be because the 12th cranial nerve is in the medulla, so it should be medial medulla. And there's a classical crossed neurological deficit. So this may suggest kind of a right medial medullary syndrome. And this is a picture from Snell's clinical neuroanatomy. And now you could see here that this is likely the place where the lesion could be. And so he has vascular risk factor and sudden onset of focal neurological deficit likely to be stroke. And then this MRI shows the typical lesion in the right medial medulla. And his right vertebral artery was not visualized, perhaps hypoplastic or dissected or occluded. So like when you have this kind of a combination, if you have its lesional cranial nerve deficit and contralational pyramidal sign, then it could suggest the sort of a brainstem localization. So this kind of a formula you can derive, just like you do a lot of formulae in mathematics. So as we call mathematics is a Kuhn of science, you can rightly perhaps call neurology as a Kuhn of clinical science. And now to show some few other cases, like this guy, young person has a stroke in young presentation, and he had this kind of tongue weakness on right side, and he had right limb weakness also. So in this patient, and I also have some facial weakness as well on the like upper motor neuron type of right facial weakness. So if you look at this patient, he had lingual paresis and the pyramidal deficit on the same side, it's not crossed. So the tongue weakness is likely to be supranuclear. Indeed, the patient had a lesion in the internal capsule actually. So this illustrates the kind of the laterality of the findings. Like if you have ipsilateral cranial nerve and a contralational long tract sign, you can localize to the brainstem on the ipsilateral to the cranial nerve deficit. And if you have kind of the cranial nerve and the long tract sign, the same sign, most likely it could be supranuclear cranial nerve deficit. And then for the brainstem localization, again, like we had one more patient I saw 2 decades ago in SIMS, like he had a vascular risk factor, he came with diplopia and he had a right facial weakness with epiphora. And to cut to the chase, like in the figure A in the top panel, the patient was asked to look up, look straight, like in the primary position of gaze. You could see the slight exotropia, like abduction of the left eye. And in figure B, the patient was asked to make a gaze to the left side. Here, the left abducting eye was of full range, but he had some dissociative nystagmus in the left eye. And there was a restriction of adduction in the right eye, indicating right internuclear ophthalmoplegia. I couldn't show the nystagmus because it's still images. And in figure C, he was asked to make a right gaze, and you could see there's a right gaze paresis. So the patient has a right INO and right gaze paresis. So this indicates more of a right 1.5 eye syndrome. His vertical gaze was normal. And you could see in the panel F and G, he had sort of right facial weakness, more of LMN. Later, after this photograph and examining, he had a weakness of the frontalis as well. So this patient has involvement of right medial longitudinal fasciculus, right horizontal gaze center, and or abducent nucleus, and also the facial involvement. So you could see a beautifully lesion close to the facial colliculus and possibly involving medial longitudinal fasciculus and the abducent nucleus or the horizontal gaze center, perhaps. So this is being called the 8.5 syndrome. So if you have 1.5 plus the 7 cranial, which is 7, 1.5 plus 7 is equal to 8.5. And you could see here the beauty of the addition of mathematical computation here. So rightly, neurology can be called as a Kuhn of clinical science, perhaps. And so the arithmetic continues. Colleagues from Korea, they found like bifacial weakness or 1.5 eye. So they call it 1.5 plus 7 plus 7. That's 15.5 syndrome. So coming back to our case number 5, if you are wakeful and if you recall the case, this guy had a lot of sleep apnea, and he had this kind of a dysphagia, etc. So whether the lesion is intrinsic or extrinsic. So here, of course, of interest, he also had bilateral laryngeal weakness and all. When we do the image, we find this kind of a lesion in the pons, which didn't show any contrast enhancement. So it is slightly hyperintense in the flare and T2 weighted image. So we don't know what the lesion was. He didn't have any acute onset of symptoms. It was slightly insidious onset progressive dysphagia with bulbar dysarthria. And then in the perfusion as well, he didn't have any significant abnormally increased blood flow at the site of the Pontine lesion. And MR spectroscopy also was not much helpful. So it is FDG PET also didn't show any significantly increased uptake indicative of hypermetabolic this thing. So he didn't have that. So coming back to the illustrating the cause of a brainstem lesion, most often we see some vascular pathology or vasculitis. So for the sake of reason, I put it along the mnemonics of vitamins, like so. And we have this autoimmune condition treatable ones like NMO, MS, ADM, or MOGAD. And then some interesting conditions like clippers and bases, sarcoid and all, also vasculitis like Sjogren's and the SUSAC and all could involve the brainstem. And also certain paraneoplastic or autoimmune encephalitis, especially anti-MATA and anti-GLON5 also could involve the brain, like present with brainstem features. And then you could have the maple syrup urine disease having some restricted diffusion in the brainstem. And then the interesting conditions like the Langerhans cells and the non-Langerhans cell histiocytosis, histiocytic disorders. They could also at times involve the brainstem. And sometimes you get a neurodegenerative, for example, Alexander's disease, which could produce a tadpole-like midbrain atrophy, medullary atrophy. And some neoplastic conditions like Pontine glioma and children and so on and so forth. And so this patient didn't have any symptomatic hyponatremia or bone lesion. And one of my colleagues started him on methylprednisolone, thinking whether it could be some like immune mediator or autoimmune. And then guess what? He had significant improvement of his dysphagia subjectively. We didn't do any functional endoscopic procedure. And then when steroid was tapered, his dysphagia and insomnia worsened. And then when he tried to offer a steroid sparing agent like mycophenolate, because he was a non-diabetic, he could it really was more steroid dependent actually. And his routine lab investigation then with a kit from Euroimmun lab from Germany was negative. The well-known characteristic autoantibodies for the autoimmune encephalitis panel were negative. And then his CSF was slightly abnormal, slightly elevated protein, but he had poorly controlled diabetes as well. And then most of the other workups were negative. And he has diabetes, he has sensory motor neuropathy, and other investigations, imaging were not very much revealing. And his polysomnography, as I mentioned, showed severe obstructive sleep apnea, and he was put on CPAP or BiPAP, which he didn't tolerate. And of interest from management point of view, had hepatitis B seropositivity and possibly latent tuberculosis. So some of these tests we didn't perform. And then later you have some Brugada syndrome and all. And then, so these are cut to the chase of the things like here, this bulbar dysarthria and with some findings that could be referred to the brainstem, that in particular to pons and medulla perhaps. And then he had a steroid responsive dysphagia. And any thought on the diagnosis? So I had a worsening of the abductor paresis, and he had stridor, he required a tracheostomy. And then there's a worry about continuing immunotherapy because he also had bronchiectasis in the chest, and he had some lot of secretions as well. And this is a serial MRI because there's a worry whether it's an elderly gentleman, whether it could be a malignancy as well. Like so, like serial imaging didn't reveal any significant progression of the brain lesion. And most of the other autoimmune, I was just pushing our clinical immunologists who were trained in Australia. So they, upon my repeated request, tried to send the sample to Euroimmun lab directly. And we had a very extensive panel of autoantibodies that have been tested. So all of them returned negative result. And the anti-Ig LON5 antibody was detected in high titer. At that time, it was just more of a research test, and Professor Joseph Dalmon and colleagues from Barcelona described that condition a few years back before this index case. So he was continued on Ig, but there's no significant benefit. And then we were forced to give him monthly methylprednisolone. Then planned to give him rituximab and with entecavir and INH prophylaxis. And so a brief overview of this anti-Ig LON5, like Professor Dalmo and colleagues from Barcelona, they described 8 patients. At that time, the patients had a lot of sleep disorders, obstructive sleep apnea as well, plus brain REM or non-REM parasomnias. And of note, none of these patients responded to a significant extent to immunotherapy. And so there was a thought whether this could represent an intersection of autoimmune disease versus a degenerative phenotype. In fact, this turned out to be an autoimmune tauopathy, but subsequent case series mentioned like significant improvement on immunotherapy. So this Ig LON5 can have 4 different clinical flavors. One is a sleep disorder, and then progressive bulbar dysfunction. And they could also mimic like PSP with gaze paresis, including vertical gaze paresis. And sometimes they could have chorea, mimicking like Huntington's. And as in noted here, our patients have really longer duration of illness, like some spanning over 4 or 5 years or something. And this is a case from the neurology subsection journal. Like you could see some changes in the brain region surrounding the third ventricle and the hypothalamus in Ig LON5. In subsequent case, I mentioned some brain lesions. Initial cases didn't have any remarkable MRI finding, and some of the lesions in this particular case had contrast enhancement as well. And this is the case of suspected clippers. This looks atypical for clippers. This patient also had Ig LON5. So do you have time, or shall I wind it up, or Dr. Lakshmi? Dr. Lakshmi, can I just proceed, or can I wind up? Like,
Till how many are there? How much time you take?
Maybe some 10 minutes. So
Because ask, I think, them whether how much is it 1 hour or this 1 hour, I'm not sure. Dr. Lakshmi Narasimhan?
Ma'am,
Hello, madam.
yeah, sir is here.
can I stop here, or can I have one more case? Like Dr. Lakshmi?
You have you'll have another 5 minutes. How many minutes you want?
A little bit longer, maybe 10 minutes, maybe. Is it okay?
Yeah,
Or
you can,
if you want, I
No,
can
it's-
close here, no problem.
no, you can.
No worries.
You can continue, please.
I hope all of you are awake. So it's getting late. Like so, this interesting case was a gentleman in his 7th decade of life. This was a referral from a nearby hospital where I was working. Like so, they sent a referral letter. So he had bilateral hearing impairment of 20 years. He had a surgery in India and UK. And then he had some vascular risk factor, and he had so basically he had some transient giddiness for which he went to the local hospital, and there they attributed that to antihypertensive. And when they did a routine chest X-ray, there was incidental interstitial changes, and there's a worry because later imaging revealed more of lymphangitis carcinomatosa like feature. He didn't have much of a chest symptom, by the way, and he had a handful of investigations that have been done in the referral hospital. So they sent all these referral details to me. And then it had a initial chest X-ray that showed some incidental nodular lesions, and it was thought to be like a lymphangitis carcinomatosa like feature. And then subsequently underwent a biopsy as well. And so the differential diagnosis of malignancy, sarcoidosis, silicosis, etc. And he also in the outside hospital he had MRI brain, which showed some pontine lesion, which was enhancing, and he had FDG PET lesion that was showing increased FDG uptake as well in the pons. And he had also a lot of lung lesions, and he had this coated aorta also, and he had a lot of bone lesions as well. This bone lesion beautifully lights up in PET. In fact, PET seems to win over all other like routine X-rays and on this particular case. And so he had a disc enhancing pontine lesion, and then the chest CT showed some interstitial perilymphatic and subpleural nodules with effusion, and that was hot on PET. And he had also had a lot of bone lesions, aortic lesions, pleural pericardial peritoneal effusions. So the possibility was whether we're dealing with a malignancy or sarcoid vasculitis of some form, silicosis, berylliosis, so on and so forth. And so they did a couple of some panel of tests, including the tapping of ascitic fluid. It was negative for malignancies, and so when they did the biopsy, they found some fibroinflammatory nodules consisting of myofibroblast, some histiocyte, foamy cells, some lymphocytes, plasma cells, and Jane cells. And so the worry was whether it's tuberculosis or fungal, but there's no cacheating granuloma or non-cacheating granuloma typical of sarcoid. So this diagnosis were unlikely. And then ESR was also elevated. And then he was finally put on some steroid with a steroid sparing agent. So the diagnosis remained by and large unclear even after biopsy. And so when I asked them to bring the patient had a recurrent vertigo. It was very brief lasting, and it was more positional. And so on looking up and rolling over in bed on either direction, to right or left, and there's some insomnia and some weight loss as well, but it was by and large not much symptomatic. To cut to the chase of things, like he had recurrent paroxysmal positional brief vertigo with bilateral hearing impairment from previous surgery, and neurological examination basically revealed a preserved higher mental function. And then he didn't have much of cranial nerve findings. So what tests we could do in this clinical scenario? So I did a Dick-Soltpike maneuver. Guess what? We were so worried because he got very intense vertigo, and it's a very typical of bilateral posterior canal BPPV. And then remember, he had a pontine lesion as well. So the question is whether it's a peripheral like BPPV or central paroxysmal positional vertigo. And so by and large, upon my clinical evaluation, I thought the jury was more of like a BPPV. And so likely the pontine lesion was incidental. So we need to think of a condition where we can put all these things together. We need to explain the enhancing pontine lesion, lung lesion, aortic lesion, bone lesions. And so there's some footprints in the imaging. So this is another case that I saw that time. Like this patient had an area posterior like lesion with paraparesis, and this lady also had lung lesion. Ultimately, they turned out to be varicella zoster related pneumonitis and brainstem encephalitis. The late Professor Donald Gilden from Colorado helped me to get all the staining and all. So again, running over this etiologies like the vitamin, here most of these findings will be explained by this histiocytosis. So applying the principle of Occam's razor. So in all the instances like this, Erdin-Chester disease, histiocytosis comes up. connecting all the dots, it turned out to be this thing. Like, so this is another case published in Brain Journal Neurology where the patient had a pontine lesion and hairy kidney, and my patient also had this enhancing brainstem lesion, and he didn't have any like posterior pituitary lesion. He didn't have diabetes insipidus, by the way, and so upon this, I just called up the pathologist and told, and then the pathologist went back and she told this was more in tune with this diagnosis. There was a lot of fibrosis in the biopsy of the lung as well as the bone. And then I suggested them to do the BRAF mutation in the biopsy as well. And I didn't have much follow-up on that case. And so this is a brief about the Harding-Chester disease, where PET could be very helpful in monitoring the disease. And so these are the two gentlemen, Jacob Harding from Germany and William Chester from US. They described that long ago in the 1930s. And this is a multi-system disease. It could be a CPC case, like with bone, brain, lung, abdomen, cardiovascular, other involvement. And so this is a bit brief review of the various neurological manifestation, including the pituitary or hypothalamic lesion, brainstem involvement, and meningioma and plaque-like lesions, brainstem involvement, and the vascular involvement, and kind of retroconal, retrobulbar involvement as well. And so in this patient, we could use this principles of pattern recognition, maybe duck principle, which states if it walks like a duck, quacks like a duck, looks like a duck, then it's a duck. So in this case, the clinical features walk like ECD, Harding-Chester disease, quacks like, sounds like ECD, and looks like ECD, so it's ECD. But if you apply the Icken's dictum, which says like a person can have as many diseases as they damn well please, so is vertigo is likely to be BPPV, likely secondary because of the oral surgery and some issues he had for long standing. And this case also illustrates the confounding thing of like, going for the high tech, like you saw like the patient was referred with all the investigations, like including the PET scan and all. But it's always good to have a kind of clinical touch. So we need more, at least in the Indian context, more of high touch medicine rather than high tech medicine perhaps. But we should not lag behind with the technology. Artificial intelligence will take us. And then the other issue is the kind of rare diagnosis. We make rare diagnosis, it is often said you're rarely correct, but this case indicates the importance of looking for the extraneural findings. And then there's another formula like this, so indicating the neurology can be rightly called as Kuhn of clinical science. If you have some key neurological findings or some pathognomic extraneural findings, then you can have the etiological diagnosis. This is also illustrated by this cases of neurocutaneous syndrome, where you can see the skin lesion, the shagreen patch, and the adenoma sebaceum, the cortical tubers, and all, indicating the diagnosis of tuberous sclerosis. And here you can see the trigeminal encephalomyomatosis is calcified, indicating Sturge-Weber's. And here you see a patient with myopathy, and he has a heliotrope rash. This is pathognomic of dermatomyositis. And so, so this cases yield this formula, yeah. And so we need to be more mindful that it's a brain that is the seat of emotion, everything. And so in the next Valentine's Day, don't put heart, put your brain as a symbol. And then, so we just went on maybe gazing from one case to another, not getting intoxicated perhaps and sleeping, but to gain some insight all the way. These cases illustrate the importance of unraveling the underlying diagnosis. Otherwise, the patient will show from one physician to another, and the physician will show from one investigation to another. So this is a brief poem that I wrote, copying the poem of Alexander Pope, the great poet. He wrote like, "Heaven from all the creatures is a book of fate, all but the page subscribe represents fate." I just tweaked it, twisted it, and wrote for a contemporary team, iPad from all clinicians, close the book of evidence, all but the page subscribe the practice guidance. From conjurers, what expert what trialists know, or who could face the dark below. The man with a stroke arrives within the time window without landmark trials. Would he receive the lytic or lytic flow? Thanks to the care, he regains his strength and wears his smile by the third month. Oh, the levels of evidence kindly describe that each may provide the care prescribed. Guys of care beyond chance of all, a pill succeed or a placebo fall. So, and then a credit for all the caregivers dealing with the chronic diseases. So this is a poem I also narrated some time back. So if life is a credit card just to swipe and spend days caring for a ailing kin, protect your code of health, else screen will wipe your transactions out for invalid PIN. So I dedicate this presentation to the bravery and valor of the caregivers of our chronic patients. Thank you for your attention. Madam, you can take over.
I really thank all my residents, like that first case wonderfully worked up, the patient with the atypical Parkinsonism. I think the message is that this message should go to all general surgeons and oncologists who do the thyroidectomy, and we should tell them that they should come for regular follow-up. Maybe if you'd have followed up once in a year or so for a calcium or some levels, maybe we can pick up and see that she wouldn't have developed. Maybe that was my this one guess. At least one patient, and now presently we can at least see that she cannot progress further, but treatable cause. And I thank all my 4 residents, Dr. Hakim, Dr. Nandini, Dr. Arun, as well as Dr. Srija for their wonderfully working up that case and presented nicely. And I thank Dr. Nandagopal for taking this initiative and preparing and workup of this case, and also all his cases like variety of brainstem localization and finally end with ACD, chest disease. And he gave a lot of clinical clues and how to approach and importance of clinical medicine. All that, it was really wonderful session. I think, hope everybody would have enjoyed. I feel proud of all my department for making a wonderful presentation. Over to Lakshmi.
Thank you, madam. Not only you are proud, we are also equally proud of the entire team. In fact, not only proud, we are a little bit jealous of the poetic neurology which was described by Professor Nandagopal, and starting from Paranjodiyar to Green Journal, I could see the multifaceted talent in Professor Nandagopal. I am very delighted, and it's a wonderful feast of starting from the movement disorders, and especially, as you rightly said, the parathyroid and the hypercalcemia and hypocalcemia are very often missed correctable causes of extrapyramidal. Then, in fact, recently, one of our senior psychiatry professor, she was taking met 3 specialists. All the 3 were giving calcium supplements in different forms. Because of the trade names, they didn't know each other that she's already taking. And this lady is in the early demented phase, so she also didn't have the clue. So all the medicines were given for the 3 specialists, all containing high dose calcium, resulted in extrapyramidal, and we also saw hypercalcemia presenting as so. For the case of the hypoparathyroidism and IG-LON, it's a wonderful feast for all the residents. I thank your entire team, madam, and for an excellent presentation. So many take-home points, starting from eye movements and especially the Erdheim Chester. And there's only one question, the question and answer box, which was there. And that was already answered. Why didn't the lesions pursue? They pursued and then made a diagnosis of. And for the sake of the residents, I want you to look up what is called emperipolysis. Emperipolysis is the RBCs, normally what happens when a cell is swollen, the pathological landmark of few of the histiocytosis is this emperipolysis, or the hemophagocytosis. They call it the hemophagocytosis. After phagocytosis, normally the lysosome gets attached and everything gets digested. Instead of that, the cell without getting lysed stays in situ. And this can be erythrophagocytosis or hemolymphophagocytosis, lot of different types of hemophagocytosis is there, and emperipolysis. There are all few short notes for the neurology postgraduates. Thank you. I thank the INTAS people who have been continuously helping us in our endeavor, and I thank every one of you, and wishing you a safe and good night. And over to Heli for our conclusion. Thank you.
Thank you, sir. We have come to an end to episode 29 of Secrets of Neurology. And I, Heli Gadani, would like to thank all the delegates for the continuous and consistent support in terms of their presence and patient hearing. Today, again, we have witnessed very insightful and unique cases, and I'm sure all the delegates would have learned a great deal out of the same. I'm thankful to Dr. Abdul sir, Dr. Raghunandini ma'am, Dr. Sai Arun sir, and Dr. Shrija ma'am for presenting the intricate details of the case. I would also like to thank Dr. Nandagopal sir for sharing the views on the case along with few other learning cases. And I would like to thank Dr. Vengamma ma'am for her expert opinion and concluding remarks. Last but not the least, I'm also thankful to the course directors for giving us an opportunity to be associated for this wonderful scientific platform. With this, I sign off for today with a commitment to see you next on 30th December 2022 at 8 p.m. with yet another wonderful case. Thank you so much. Have a good night, everyone. Thank you, ma'am. Thank you, sir.
Thank you. Thank you, Dr. Lakshmi.
Thank you.
Nice.
Thank you.
Thank you.